you very much, everyone. And thank you, Stephen, for the 2 years of mentorship in this whole process, for the presentation of the today, and for the grant, and for the research. So thank you very much. And for the team too. So today, I'm Kevin Zemmour, psychiatrist. So I'm a clinician. The research interest is very young. And so I will speak more as a clinician today, and we will see some preliminary data, very limited. So I will speak about the brain glucose and ketone uptake and metabolism in first episode of psychosis. So as I'm a doctor, what I will speak today does not constitute a medical advice. And I will speak about the metabolic psychiatry, so the use of the central metabolic insight in psychiatry, and it will not replace medication, and we will use medication in conjunction with the metabolic interventions. So the plan for today is to speak a little about the metabolic psychiatry, the first episode of psychosis, the central metabolic hypothesis in psychosis, and the ATP project. So the ATP project for antipsychotic, PET scan, and psychosis project. So we go a little in the psychiatry. So before 1951. If you had a mental health issue, you will be placed in an asylum. But since the discovery of the chlorpromazine antipsychotic, the first one, large actil, so the large action of medication, we target the symptomatic recovery. So for the mental health issues, we target the positive symptoms, which means the agitation, the voices, hallucination, and delusion. But the patient were very impacted by the medication, by the dosage. So we shift to the functional recovery. So we want a person that function and we target more the cognition, the functioning of the patient, and the negative symptoms. So you will hear today about the positive and negative symptoms. Mainly the positive symptoms, it's the symptoms that are added to the brain. So voices, hallucination, and delusion. And the negative symptoms, it's the invisible symptoms. So is there a question? I heard voices, sorry. And so the negative symptoms is the lack of motivation, the lack of pleasure, the lack of interest in socialization, and the reduced verbalization, or just to speak with very limited amount of word, and blunted affect. So it's a person that looks like depressed, but with no depression, with psychosis. And then we can switch to the personal recovery. So it's what we do now in psychiatry. So we focus more on the quality of life and the objectives, the plan of the patient. So if we take the three together, so symptomatic, functional, and personal recovery, it's what we do right now in psychiatry. But since 5 years now, around 5 years, there is a new movement that target more the cellular part of the mental health. Okay, so before it was more the consciousness and the person, and then it's more the cellular. So it's quite new that psychiatrists focused on the cellular, how the brain cells function to help the mental health. What is the first episode of psychosis? So it's the first episode of experiencing delusion. A delusion, it's a thought that is not shared by the culture. And it disrupted, disorganized thoughts. So it's sort of the thought that's very disorganized. So you think of something and then you switch to another thing without logic. Yeah. Hallucination of the five senses, mostly the auditory hallucination of the voices, and the negative symptoms that I spoke earlier. It touched the young person, so between 16 and 35, but there is a second outbreak for the woman at the menopause phase. But today we will speak only for the young person. The prognosis of the first episode of psychosis is poor if it's not promptly and effectively managed. So we need to have the duration of untreated psychosis the shorter possible. And we need to avoid the relapse. And what is a poor prognosis? So it means chronic symptoms, isolation, and removed from the social network. So the person is on welfare and doesn't work or doesn't go to the study. The chronicity is associated with symptoms. Reduced response treatment, it means that if you have like a psychosis for a very long period of time untreated, then you start the medication, the response is less good. And the same if you have relapse. At the end of the day, the medication is weaker and weaker. There is the stress axis dysregulation at the beginning of the disease, but also in the chronic course. There is insulin resistance and atrophy of some brain regions. And the most important, the quality of life is decreased when there is chronicity in psychosis, and the life expectancy is reduced of 20 years. We don't know so much the causes of the first of psychosis, so we call that the multifactorial causes. So it means the bio-psychosocial causes. Yeah, bio, it's genetic and drugs, but also the food and psychological. So it's the trauma and the education, and social could be the immigration and the poverty, the low income in the family. But when we teach the psychosis in university, the central metabolic causes are really underestimated, and we don't speak about that too much. And it's why I will speak to you today. The treatment. So we combine a FEP clinic, and today we have members of the clinic. And with the medication, it's antipsychotic medication. So the FEP clinic is to pair a patient with a case manager, with the doctor, but mostly the case manager, and to work on the needed adaptive treatment. So what are the needs of the patient, the client, and we will help to go to respond to the needs. And also the medication. So it's antidopaminergic medication, first, second, and third generation, maybe the second and third one. But what I want to highlight is that it's a symptomatic treatment. Okay, so we treat only the symptoms of the disease and not the roots of the disease. And mainly we help with the fear. So you can imagine you have delusion, and you have a huge fear, okay? And when you have a huge fear, your brain will start to be in a survival mode, and will try to understand what's happening in your life. And you will build a narrative that we call a delusion to answer to the break of the understanding of your life. So if we try to reduce the fear of the patient, so the emotions, so the delusion is not needed anymore. But if we reduce the emotion side of the person, you will have more blunted affects. So you will increase you will maintain or increase the negative symptoms. So it's one of the side effects of the medication is that it's not helping with the negative symptoms. And we know that the negative symptoms are very important for the quality of life of patients. Also, the medication has a lot of side effects, like metabolic side effects, metabolic syndrome, diabetes, dyslipidemia, insulin resistance, also so the weight gain and the decrease of the libido. The libido is the willingness to have sexual behavior, and the fatigue. Okay, so the patient feel numb, feel like a zombie under the medication. So it's very important that the medication is not so we use it, but it's not like so we can improve on that side. There is a poor adherence to the medication also because of the side effects. And we don't have any treatment for the root causes of the disease. What is important? Sorry, I go back. So when you start the first episode of psychosis, we will prescribe the medication for 1 year and a half, and then we will try to stop it. But it's at least 1 year and a half. It's a transdiagnostic population. So if you do the first episode of psychosis, we don't know how this episode will evolve. So perhaps it will there will be no more symptoms and no relapse after, but it could also evolve towards psychotic disorder like schizophrenia or delusional disorder. It could evolve as a mood disorder like bipolar disorder, and also in substance use disorder and personality disorder. But I will not speak today about the last two ones. So it's very important that we have, so when we do research on first episode of psychosis, it could be a patient that will not relapse, but a person that will relapse in schizophrenia and a person that will relapse in bipolar disorder. So if we find some shareable results or insights, it could means that we have the sharing same roots. So the hypothesis, what are the roots, the metabolic roots, the central metabolic roots? So there is two expert review or perspectives that are important. So, but what we see is that there is a dysregulation in brain energy starting in the pre-symptomatic phase. So before the disease, before the first episode of psychosis, there is already impairments in mitochondrial ATP production in neurons. And what we understand is that there is two waves of compensatory mechanisms involving glucose metabolism, because if you don't do a keto diet, your main fuel is the glucose. So there will be first a hypermetabolic state, mainly preclinical, with the overall ATP level is preserved. And then there will be a hypometabolic state. It will be the symptomatic state. And regional ATP level could be decreased. So in the blood-brain barrier, the glucose goes through the astrocytes, and the glucose with the glycolysis goes through pyruvate, then lactate that is shuttled in the neuron to be reconverted to pyruvate and enter in the mitochondria to produce 30 ATP. And also with the other pathway, the glucose underway the glycolysis to produce 2 ATP and then 30 ATP in the healthy situation. So with 1 molecule of glucose, you can produce 32 ATP. So this is the healthy, it's a simplest way to see the glucose pathway, but it's important to have this balance. But in psychosis, we have in early psychosis, we have the ATP production that is impaired. So we have impairment in the pyruvate dehydrogenase, and also in the Krebs cycle, the oxidative phosphorylation. But overall, it means that the ATP production by the mitochondria is impaired. So what we hypothesize is that there will be an increase in the glycolysis. So there will be more +2 ATP that will be produced. So by increasing the glycolysis, it will compensate the overall production of the ATP. But you need to understand that if you increase, so it's a glucose consuming pathway. So if you increase the glycolysis, you will increase the consumption of the utilization of the glucose. So it could mean that you will, the risk is the glucopenia. Okay, so the level of glucose will drop in the neurons and in the astrocytes. So it's important to look at the glucose level in the blood, because it will in the brain there is no reserve or very small amount of glycogen in the astrocyte, but there is overall no reserve of energy in the brain itself. So it relies highly on the blood level, on the glucose level in the bloodstream. So I repeat, in the early stage of the disease, the psychosis, there is impaired mitochondrial ATP production plus increased aerobic glycolysis. Why aerobic? It means that even in the presence of oxygen, so aerobic, in the presence of oxygen, the glucose, the pyruvate will not go will be converted in lactate and not enter in the mitochondria. It mimics the Warburg effect in the cancer. So if there is an increase in aerobic glycolysis, it means that we have to see glucose hypermetabolism, because there will be an increase of glucose uptake in the brain. However, the glucose is siphoned by glycolysis and cannot play the other roles. Okay, and there will be also lactate accumulation, and lactate is known to be a fuel, but also to be a signaling molecule that inhibits the activity of the neurons. In the chronic state, the hypothesis is that there will be still the same impairments, but as the glucose increase and the cortisol increase and the insulin increase, there will be brain insulin resistance, and then a decrease of the glucose uptake by the neurons. So you will have two problems now. Before, you have only the ATP production that is impaired, but now you have also the glycolytic ATP production that is impaired. And you will have glucose hypometabolism. And we have a meta-analysis in 2022 that show a hypometabolism in the frontal lobe, and it's correlated to the negative symptoms of schizophrenia. So we're here for the Keto Celebration. So are ketones able to bypass the mitochondrial dysfunction in psychosis? So probably yes. And I will present two studies to answer to this question. and also is the ketone metabolism intact in psychosis, and this is unexplored. So it's why we with Stephen and the team, we have started the ITP project. So the first study is a retrospective study from Dr. Danan. It's a French in Toulouse, and he with patient suffering from severe persistent mental illness. That means severe depression, severe psychosis, and severe bipolar disorder with resistance to the medication and with poorly controlled symptoms. He started a ketogenic diet, so less than 20 grams of carbohydrate per day, or around the means is 2 months, but there is very variability in the duration of the keto diet for the patient, and 100% of the patient has reduced symptoms. So it's a dramatic results, and also 43% of the patient with clinical remission. We don't have that with the medication, okay? So it's a very dramatic, unexpected results in psychiatry, and also with the weight loss, and there is a decrease in the prescription of medication. So I will not dive in the studies today. So the second one is a pilot trial from Shebani Sethi, and the same kind of patients, so bipolar disorder and schizophrenia, and they underwent 4 months of ketogenic diet, and there is a really good adherence to the diet with ketones level upper than 0.5 millimole per liter at least 80% of the time, and there is a 100% metabolic syndrome inversion and improvements at almost 80% of the patient that have. So 80% of the patient have clinical improvements. So now that we know that there is the ketones can help with the symptoms, we need to know if the ketones are the metabolism of ketones is preserved by the in the psychosis. So we studied in early psychosis, we assessed the brain glucose uptake before introducing the medication and 4 to 6 weeks after introducing the antipsychotic medication, and we assess the same the brain ketone uptake too. So you have to understand that it's quite difficult to include this patient, because I'm the doctor of the clinic, so the patient come and I say, okay, you have a first episode of psychosis, but if the patient is very severe, I will propose the medication immediately. Okay, but if the patient is not so severe and we can wait 10 days before introducing the medication, we will offer the research projects. Okay, so we have started the inclusion in 6 months, I think, right now, and we have only 2 patients. Okay, because we include a lot of patients in the clinic, but that require all the inclusion criteria. We had only 2, and so we published the protocol in +1, and there is multiple actors, but there is 2 sites, okay, of the same study. There is the site in Aarhus in Denmark and the site in Sherbrooke here, and we work also with Maggie Han in Toronto. So the eligibility criteria is the patient that I meet in the clinic for the first time, and then they have So the age is between 18 to 35. It's outpatient or inpatient, but naive to antipsychotics. Okay, we don't want patient on under antipsychotic or fast antipsychotic medication uptake. We know a very small amount of Abilify and quetiapine that are antipsychotics, but at low dose, it's just helping for anxiety. And we exclude psychosis with intellectual disability, autism, spectrum disorder, substance use disorder with decompensation, and also psychosis induced by drug or withdrawal. And type 1 diabetes. Type 2, we don't have that. As the patient is very young, they don't have type 2. So we have 2 patients in Sherbrooke that I will present the results, and 3 patients in our route, but we don't have right now the results. So when the patient, so it's important how the patient come to the clinic. So it's an auto-referral call. So they call Veronique, that is just here, or Jennifer, the 2 person that take the calls, and they say, okay, I hear voices, or my son hear voices, or my daughter hear voices, and we say, okay, we will meet you in 1 day, 2 days, and for the doctor, it's 7 days or 2 weeks to see the patient, so it's very quick. And if the patient has the criteria of psychosis, plus we can delay the introduction of the medication, we propose the protocol, and they meet the team of the research team. They do the health history and anthropomorphic measures, and then we start the imaging with the dual tracer PET scan plus the MRI to localize the region of the brain. And we do also some blood work, the metabolic blood work, and also the hormone blood work. And we go through 10 days of continuous glucose monitoring. After that, when we have done the imaging, we will start the medication. Okay, and then we will adjust the dose. So it's a real patient. Okay, so if we have to increase the dose, we will increase the dose, reduce the dose, we will reduce the dose. And if we have to change the medication because of side effects, we will change the medication. So it's real, it's not a laboratory patient. So we will treat them and help them as usual. And we will do, after 4 or 6 weeks, we will do the same, we will repeat the same measures. At the end of the study, they remain on an antipsychotic if they want. Okay, if they want to stop it, it's the game. Okay, so for the patient, right now we have 2 patients. One was a duration of introduced psychosis of 2 months, and she experienced voices and hallucination. We have started the Abilify. It's antipsychotic medication of 3rd generation with a low profile impact on the peripheral metabolic status. But at the end of the project, so the medication worked, but she dropped in depression. So at the end of the study, the diagnosis is bipolar disorder. So with a manic disorder with psychotic symptoms, and then now she had a depression, but now she's euthymic. So she's clean with the mood, but now she's not anymore on antipsychotic. She is on the lithium. And the second one, the duration of introduced psychosis is much longer. It's 2 years, and the person start the medication. It's risperidone, that is moderate to high on the impact on the metabolic status. But not at the end of the study, but 2 weeks after the person stopped the medication. Okay, so during the imaging, we do the PET acquisition, and then the ketone PET acquisition, and then the glucose one. And the question. So in early psychosis, the uptake of glucose, is it stable or increased? And after the medication, so in the field of the psychiatry metabolism, we think that the medication impact negatively the uptake of the glucose in the brain. So the question is, the hypothesis is that it will decrease the uptake of the glucose. And for the ketones, we don't know. So the results. So on the left is the ketones, on the right is the glucose, the control. So I will speak first for the glucose. So we can see that between the glucose, the controls, and the patient before the naive patient, the naive to the treatment patient, so that there is a small increase of the glucose uptake, and after 4 weeks of medication, there is even more uptake of glucose. But I will show you the numbers after. It's a small number, so it's a 12% of increase from here to here. So after the medication, there is 12% of increase. And for the ketones, it's quite the same. So the same increase. So the same increase, but the levels are higher. So between the control and the psychosis without medication is at least almost 30% of, sorry, I repeat. So before the medication and after the medication, the increase of the capacity to take up the glucose is up to 30%. Okay, so what it means? It means that the brain crave of fuels. Okay, so the brain wants more fuels. It could be glucose, ketones, lactates. So we don't know so much, but the meaning is that there is more uptake. So this is the table. So so what I want to show you is the numbers in green. So it's for the patient before and after the antipsychotic medication. So for the glucose, it's an increase. The door is more open for 12%. And for the acetoacetate, the ketones, the door is more open for 30%. For the control, so it's a dramatic result, but the fasting was not the same for the patient and the control. So we have the result, but it's not meaningful for today because we have only two participants and they are not fasting the same way. So for example, the patient, it was only 4 hours of fasting, and for the control, it was 12 hours of fasting. So as there is more ketones in the plasma, the result is different. So I will not speak I will not focus today on that. So there is a lot of limitation in this project. It's a small sample, so we will have 10 participants in Sherbrooke and 12 in Aarhus. It's an observational study, and the results will they should be viewed as preliminary and to inform future research. And also, we didn't look at the life factors in this. So I will acknowledge the Stephen and the team and the FREP team and the funding. So the Bazuki Brain Research Fund and the New Frontier in Research Fund, the co-investigator, and that's it.